Hi, welcome to this section of cardiology. This is Dr. Jaitly. In this particular section, I'll be trying to answer the very commonly asked question, what is infective endocarditis? In a very basic way again. It's a very, very vast subject, very exhaustively written in textbooks and medical journals, so please go ahead and supplement this information with others in order to really become an expert on that. But the fact is that I can give you some basic aspects as to what infective endocarditis is. Chiefly understanding what it is and then how it's defined and what are the criteria and where is the high risk prevalence. So any infection of the endothelial surface, which most likely is a bacterial infection. Endothelial surface is the inner lining of the heart. Chiefly the valves are affected, but the chordae where these valves are attached to, they're small parachute-like structures which are attaching these valves. I've not shown them in my schematic here on the right panel, but they exist. And the mural surface, which is the surface other than the valves of the inner lining of the heart, that is called the mural surface. So what have we learned so far? Infective endocarditis is an infection, mostly of the bacterial type, involving the valves, the mural surface right here, or the chordae where these parachute-like structures attach themselves to these valve leaflets. There are two common types of infective endocarditis. One is acute and the other is subacute. Now the acute variety is obviously, just like the name suggests, is very progressive, very toxic presentation where the patient immediately develops fever and chills and loss of weight and has these valve infections rather fulminantly developing into, and then they can even dehisce, or they could develop fenestrations or small holes, and that's a very serious thing. So acute endocarditis is not free of any complications. It's rather very progressive if it's untreated. So the course is extremely fulminant. And normally the organism that's inculcated with acute is Staph aureus. Just remember that. The subacute variety, which takes weeks and months to develop, can have a low-grade fever for a longer time, for several days to weeks, before patient starts to feel unwell and then starts to have more problems, including some peripheral lesions in the skin, for instance, or some nodes, or then a new murmur can develop within the chest, etc. And then the doctor examines and sends somebody to get an echo at a cardiologist's office, and that's where one sees vegetations, or the patient comes to the hospital and gets admitted, and then they use certain criteria. Now there are certain risk groups one should be aware where the risk is higher per se for infective endocarditis. Remember, you and I, we all get some infections, like a viral infection, sometimes even a bacterial infection, but doesn't necessarily mean that we'll have an infective endocarditis. So you have to have some risk factors in order to develop infective endocarditis. One, of course, if you leave the infection untreated, the chances are it gets into the bloodstream. So the infection has to be in the bloodstream first. Okay, and once it's in the bloodstream, that's when the infections can occur if the valves are more prone. Now, which valves will be more prone? These are the criteria. Here we look at them. One is rheumatic heart disease, which commonly affects the left side, the mitral valve or the aortic valve, like I'm showing you here on this panel. Then you have the congenital heart disease. Now, congenital heart disease obviously will be either a PDA, which is patent ductus arteriosus. We'll talk about that at a different level, but just remember PDA. ASD, I've talked about it in my different other video presentations, where there's a hole within the interatrial septum congenitally, a septal defect we call it, ASD. Here is a VSD, which may be also prone for, where there is a hole within the ventricular septal region. And then you have bicuspid aortic valves. Somebody who is born, remember, aortic valves and pulmonary valves and tricuspid valves, they are tricuspid. They have three leaflets, 1, 2, and 3, like I've shown here. Similarly, we have 3, 3. Mitral is the only one which has bicuspid 2 always. That's why it has only 2 leaflets, as I've shown. So if the aortic valve has 2 leaflets, it becomes a little more prone for infection, because there will be some regurgitation there present all the time, or it has an inherent tendency to get infected. Then there are AV shunts, whether it is a dialysis patient, for instance, or there are AV shunts in general present from congenital reasons. IV drug abuse is a very special category which is present in developing and developed countries in all strata of life, and chiefly affecting the right side of the valves for obvious reasons, because the infection comes from not so clean needles, and therefore bacterial infection can immediately harbinger on the right side because it's coming via the veins, and all veins are pouring into your right atrium. So obviously, which side will get affected first? The right side, because they're pouring into the right side first. So the tricuspid valve gets affected, and therefore the pulmonary valve also can get affected. But then the left side, because the infection is traveling all around, then these valves on the left side can also get infected or affected at a later time if left untreated. But the commonest organisms here again will be Staph aureus, and they're very, very fulminant lesions, unfortunately. So this becomes a very special high-risk group. Mitral valve prolapse, where the prolapsing of the valve occurs into the left atrium, and with the regurgitant lesion that follows after that, that regurgitation damages the valve leaflets, and as a result, they are more prone for infective endocarditis. Degenerative heart disease or valves is where the valves have regular wear and tear from the old age. Prosthetic valves is a very, very common entity, unfortunately, in developed countries as well as in developing countries, where the valves are now being increasingly replaced at a higher rate, whether they are operated upon or even while they are being inserted via the peripheral, it's called the TAVR, that is transcutaneous, say, aortic valve replacement, or TMVR, like transcutaneous mitral valve replacement. That's done via the venous route, even without opening the chest. So prosthetic valves have a special entity where they get infected, so they have to be very, very cautiously approached, and that's a different category altogether. There are certain diagnostic clinical criteria. One of them, let's move it to the left panel for a second. When somebody does an echo, which is an ultrasound technique of the heart, when you do an echo, you will see either a changing regurgitation within the mitral valve or the aortic valve, a changing murmur, like somebody had a mitral regurgitation, it was like 1 plus or 2 plus, now it is 3 plus or 4 plus, especially with all the other stuff going on, like there is a bacterial infection, patient has fever, patient has loss of weight, has been sick for weeks, and now presenting with to get an echo to find out what that murmur is. Now the murmur shows that actually the regurgitation has worsened. So these are the patients it becomes a criteria to diagnose. Sometimes the vegetation is so evident on the valve. Now this is the first time I use the word vegetation, so let me explain that first. There are platelets and fibrin that will accumulate after any abrasion that occurs on your skin or any lesion in your gums. Same thing happens to the valves. There will be platelets and fibrin, or the first line of defense, I call it all the time. The macrophages or the white cells will just come and try to control the infection. But as a result, a scar tissue is formed, and that healing abrasive scar tissue process continues till the regurgitation actually even worsens. And so left untreated, this vegetation develops, and those vegetations can be seen now macroscopically through an ultrasound technique. And you could see like tiny little dots here, if you will, and they are echogenic because they are reflecting surface, so they will be seen on the surface of the valve leaflets. So that becomes a criteria, very important criteria for in diagnosing infective endocarditis. Minor criteria, I'm not going to delve into those, but the major criteria is establishing a blood infection, suspecting any of these criteria risk factors, any of these categories, chiefly the drug abuse, for instance, prolapse, prosthetic valves, rheumatic heart disease, and then, of course, worsening regurgitant lesion and vegetation seen on an echo. I thank you for your attention, and let's move on to the next, and I'll be discussing infective endocarditis again. See you later, guys. Bye.